Yeah, sports cardiology is a nice developing branch of general cardiology. It's actually been in development now for a number of years, kind of as on a sad beginning. It's probably about 30, 35 years ago where an event occurred on the basketball court where Owen Brown in the University of Maryland collapsed suddenly. And it's a shock when you see a fit, healthy 20-something-year-old suddenly drop dead as a lightning strike event. And it was one of those media capturing events. And not that long after, another basketball player, I believe of the same division and same college, had a similar event. And a mystery illness and perhaps a concerning course of events was unfolding. And every so often, perhaps once a year, you hear around the world about a soccer player or a football player collapsing or some marathon or triathlete having trouble on the field. So it's definitely something that's emerging, and as we live more of a lifestyle-conscious, modifying, exercising routine that we were all trying to do, people come to us and they ask, am I cleared for exercise? Is it okay that I start? There's team physicians who have to follow protocols, and then there are community doctors who kind of do this on the side. And you know, the NFL player and the NBA player are different from the kid playing soccer and the teenager, you know, playing baseball or volleyball, or the swimmer, or the weekend, you know, triathlon person. Everybody's different, and you know, I have colleagues who work with the different major league teams, and they have to work with the athletic departments and the trainers and properly screen people. And they go through a litany and battery of big-time tests. And a lot of these players are just different from the normal, so they have to work with different ranges of normality. So different again from the everyday person. Now the community doctors who properly have to screen people can do so basically as an outgrowth of what we already do. Proper EKGs, echoes, stress testing where appropriate, but that doesn't shirk the responsibility of doing a good history and physical exam and high-quality studies thereafter, just to make sure that what is the family history? If you don't know, that's not good enough. I want an introduction to the family and tell me what's going on in the family. And a lot of times it's a difficult discussion because the players, the athletes have a scholarly activity and they have monies involved, and the athletic department has a different agenda too sometimes, and a lot of different competing interests are at play. But you want to do as a physician and a healthcare provider the right thing for the player and the athlete. It is, and just coming off of an American College of Cardiology meeting myself, a big intensive there is the sports cardiology division, and this becomes a hot topic issue because, you know, when there is a media event of somebody dropping of a cardiac arrest on some field of play, even though it is a low event rate, it is a national trigger for what else can we do. Let's do screening on everybody, and that discussion is a very tough discussion because if you screen every EKG, every athlete from high school and everybody playing, you're going to have a lot of false positives. The testing may not be of good quality, and then it's going to lead to perhaps banning people inappropriately or restrictions with unclear future status. I think certain sports are higher risk than others. I think people who are long endurance, lifetime runners, let's say at very high risk, very high rates of activity, probably is not the best. People who do high intensity interval type activities, depending on what they bring personally to that level of sport, is perhaps risky too. But maybe a little bit better. You know, it depends. Some people come to the table with a certain body style and type, and let's say if there's a risk of what we call cardiomyopathy of one form or another, or enlarged heart, or perhaps concerning EKG that puts them at higher risk. Sometimes they are allowed to compete, but they're not allowed to do some higher intensity activities. So basketball players need to be screened differently from, let's say, a long distance runner or rower or a cyclist. Let's say a young person with an arrhythmia, it doesn't present itself and rear its head until there's a major stress like a triathlon. And we try to pre-screen this early on, and if we can, we get rid of the arrhythmia and allow them to proceed if they're otherwise fine. If they're a middle-aged person who's just suffered a heart attack and they have a stent, and they have known coronary disease, but they want to participate in a triathlon, we need to properly screen them. We need to make sure that they can tolerate a good amount of exercise. Something about triathlons, though, the fitness has to be very high for someone to participate in running, bicycling, swimming. And sometimes even very fit athletes have, when they change the different type of sport, different consequences, and their body has to be able to quickly adapt to very difficult, stressful environmental changes, in addition to whatever the weather is. Hard to say. I mean, if you look at some of these autopsy reports, I don't, but I've heard that, you know, again, a diagnosis of cardiopulmonary arrest ultimately is what everybody dies of. So, you know, what's the inciting event? If you parse out the data, perhaps with swimmers, there's something that's been termed cold water immersion pulmonary edema, especially in the water changes that are maybe if they're not using proper wetsuits, and the water temperature is colder than they're used to, just like a heart failure patient can get into trouble with fluid shifts and edema and so forth. Same thing can happen suddenly with even a fit person with changing water temperatures. So that, or an arrhythmia of some type. Some people just genetically have tendencies for so-called long QT syndrome, arrhythmias, other supraventricular tachycardias, let's say, and they can suddenly shoot off into an arrhythmia that could be lethal.